The subcommittee will come back to order. Thank you, Dr. Azar, for your patience. And I now would like to recognize the gentleman from Virginia, Mr. Griffith, for his, is it 4 minutes? 4 minutes of questions.
Thank you, Madam Chair. Appreciate you being here. Thank you so much. The President and your agency have expressed concerns with the middlemen in the drug supply chain, pharmacy benefit managers, PBMs. Over time, PBMs have morphed into under-regulated entities with opportunities to exploit their position in the middle of the drug transactions in the U.S. For example, according to a new report from XIL Consulting, which is run by a former Express Scripts executive, PBMs benefit from an obscure fee known as direct and indirect remuneration, DIR. I know you're familiar with that, at a rate exceeding 500% per prescription as compared to the average administration fee. Last year, the administration proposed a rule to address these DIR fees, but later withdrew it. Do you still have plans to implement accountability measures for PBMs? And if so, what does that regulation look like?
So I remain very concerned about the DIR fees and their impact, especially on America's community pharmacists as well as independent specialty pharmacies. So the reason that we did not finalize that rule, and we were very transparent at the time, was the concern that if we forced the DIR fees to basically go through to the benefit of the patient, that could cause an increase. The middlemen would jack up the Part D premiums for our seniors, and that was the concern, and the President just has been adamant that he does not want to run the risk of Part D premiums going up. So it remains a priority for the administration to deal with this issue. If we ever could legislatively, that would be useful also.
Well, and as you know, I would love to have a legislative solution, but we thought this might be a good test case to do it with that.
Maybe even through, if we could get bipartisan, bicameral drug pricing legislation, that might be a vehicle to have that in there.
It might be, and blatantly unconstitutional. Have your lawyers advised you that that's the case in their opinion as well?
I've not had anyone study the constitutionality issues on H.R. 3 about the penalty amounts and whether that would work. So I haven't seen any analytics on that.
Well, anytime they want a discussion on it, I'm more than happy to facilitate one. Let's talk about opioids, because I only have a little bit of time left. Over the past few years, there's been a lot of talk about how they're prescribed in America and how pain is medically managed in general. And I will tell you that I thought we were on the track of getting our healthcare professionals to back off of giving out so many opioids for pain. But I have a friend who is currently undergoing some procedures, and we were talking yesterday about how they had given her opioids, how she took it in the initial day after some painful procedures, but that after that she turned it away, but they, she's got it sitting in her house. What has this administration and HHS done to reduce the overprescribing of opioids?
So we've actually, through the CDC, put out guidance to professionals on appropriate prescribing. We continue to work on even further titrated by different pain areas on what the best guidance is to do that. It's distressing to hear that. We've seen, though, an over 25%, I believe, decrease, maybe 30% decrease in the opioid prescribing of legal opioids to date since the President took office. So we're making progress, but of course it's disturbing to hear any pockets like that.
Well, and look, it's going to take time, but we can't, just because we've started to solve the problem, we cannot think it's solved, and we cannot take our foot off the gas pedal in trying to make sure that we don't overprescribe, and then with that we deal with this issue. It's very serious in my district and many others. I thank you very much, and I yield back.
Gentleman yields back. The chair is pleased to recognize the gentleman from Oregon, Mr. Schrader, for his 4 minutes.
Thank you very much, Madam Chair. Thanks for being here, Secretary Azar. Appreciate it very, very much. I'm going to leave my coronavirus questions to the next panel, but we do want to make sure the CDC is fully funded, and a little concerned about the original budget. Glad to see some changes coming forward. My questions, first question is on Medicare Advantage. It's a huge program in Oregon and many, many states. Leverages our federal tax dollars to maximum advantage. Most Oregonians, most seniors get a lot of their prescription drug coverage from Medicare Advantage. Very concerned that this administration, and frankly others, have tended to try and cut Medicare Advantage programs. I think that's foolhardy. The whole goal here is to actually make sure that these savings from the Medicare Advantage are plowed back into making sure there are more benefits that are covered, better prescription drug coverage, and expanding it to a larger universe. So could you give me some assurance you're going to continue to, this administration, you will try and continue to improve the Medicare Advantage program and not take away the savings that can be plowed into more benefits for folks?
No, absolutely. So I'm actually under direct orders of the president in his Medicare executive order to enhance and protect Medicare Advantage, exactly the things you're talking about. Offer more supplemental benefits, make sure people make those plans as attractive as options for people as possible.
All right, just saw guidelines on reducing caps and that sort of thing that made me nervous about what the intent was. Second question's on the proposed Medicaid rule. Hear a lot about that back home. Many states, I was budget chair for my state back in the day, and seemed like a great opportunity for states to, again, leverage federal dollars with state tax dollars, actually with private hospital dollars and long-term care dollars. It was a really smart use, I thought, of taxpayers' limited ability to finance the programs they want. This really made great use of the dollars. I'm very concerned with this new MFAR rule that you're going, ostensibly it's with all due respect, framed in the guise of transparency, when indeed it's a backdoor attempt to take away matching funds, the ability for the provider tax to be leveraged in many states, including ours. So I guess given the fact the executive order requires federal agencies to perform this regulatory impact analysis to determine the effect of the impact of the proposed rule, but the proposed rule says the fiscal impact of the Medicaid program from the implementation of the proposed rule is unknown. Do you consider that to be a comprehensive regulatory impact analysis?
I haven't looked at the reg impact analysis there, so I don't know the specifics on that, but certainly I do want to assure you we are hearing the feedback from you and others and governors about this. We are looking at this not to be penal, but rather to make sure that those intergovernmental transfers are genuine state money that's getting matched and not funny money or schemes. That's really the intent, and to also be more prospective, not penal, looking backwards as much as we can. So I appreciate getting this feedback. We're hearing a lot of it, and we're taking that in.
Well, what some people would call funny money schemes, others would call smart financing, and using the accounting system the way it's been established for decades to maximum advantage, it would really put a huge hundreds of $1 million hole in the Oregon State HHS budget. So I'd urge you to back down on that a little bit, or at least give it some more serious thought. And I'll yield back. Thank you, Madam Chair.
The gentleman yields back. It's a pleasure to recognize the gentleman from Florida, Mr. Bilirakis, for his 4 minutes of questions.
Thank you, Madam Chair. I appreciate it very much. Secretary Azar, thank you, first of all, for your leadership. I appreciate it very much. And thank you for your responsiveness to a lot of my constituents' concerns as well. Again, we've begun to make progress tackling our nation's opioid crisis, and HHS has played a key role in that effort. Thank you for your continued support, of course. Do you feel, and this is a budget question, do you feel HHS has the necessary resources to continue to implement provisions of the 2018 Support Act and the 2019 HHS Pain Management Task Force recommendations?
I do believe so. In fact, we've increased funding for opioids in this budget.
Okay, very good. Also, next, the community health centers, as you know, do a wonderful job. The funding is expiring soon. Now, we reauthorized it for an additional 7 years, and that's a great thing. But again, how do community health centers serve as a gateway to integrated care for individuals with mental illness and substance use disorder?
You know, more than 28 million people rely on HRSA's community health centers that we fund. They're a critical part of our primary care network of preventive care for individuals, and they deliver high-quality service. And we're using them also as part of the Ending the HIV Epidemic program to reach the underserved and reach people that we need to bring into treatment and prevention. More than 93% of our 1,400 health centers provide mental health counseling and treatment. 67% of them provide substance abuse services. I think the number is 60% of the clients of community health centers, I believe, are ethnic and racial minorities. I'm always just so impressed when I visit them, the quality of care and the quality of service there.
Absolutely. Do you have anything to add? Because I want to give you an opportunity to add, because this is a big issue affecting our constituents, obviously, on the insulin pricing. I know that this has been mentioned in committee, but if you could maybe elaborate on that, I'd appreciate it very much.
Well, I appreciate that. I did want to clarify one thing from Mr. Walden's question earlier regarding a piece of legislation. I misheard about, I guess it's a proposal to cap out-of-pockets at $50 for insulin. The administration does not have a formal statement of administration position on that piece of legislation yet. Of course, we want to get out-of-pockets down. We want to deal with the insulin issue and get insulin pricing down for everybody. But we don't have a formal statement yet on that issue. The Part D reforms the committee's worked on, and that has a lot of bipartisan support, though, that could be such a benefit to people. That catastrophic cap at $3,100, spreading that cap over 12 months where no senior would ever pay more than $258 a month for their prescriptions if they opted into that. What an incredible thing we could deliver for America's seniors if we could get bicameral, bipartisan action on that.
Absolutely. Well, thank you for clarifying that, and of course, we'll follow up with you because, again, this is a big issue affecting our constituents. How does the budget address school safety? I don't have much time, do I? How does the budget address school safety and the mental health needs of our students?
So we fund Project Aware in here, which is a really important school-based school safety program for mental health services. We have Healthy Transitions funded, which improves access to mental disorder treatment and related support services for youth. We have the Safe Schools Framework Implementation Toolkit to help educate teachers and administrators to identify kids in crisis who need mental health intervention. That's part of it.
Very good. Okay, thank you very much. I appreciate it, Madam Chair.
The gentleman yields back. It's a pleasure to recognize the gentleman from Massachusetts, Mr. Kennedy, for his 4 minutes of questions.
Thank you, Madam Chair. Mr. Secretary, thank you for being here. This week, the DHS implemented their wealth test for immigrants nationwide. The early estimates show that the rule could lead to 4.7 million people withdrawing excuse me, from Medicaid and CHIP alone, many of whom are legal immigrants, the children of immigrants, asylum seekers, and refugees. Yes or no, sir, nearly 5 million people forced to forego their health coverage. Is that a success?
We do not believe that individuals who come to this country should be dependent on public taxpayers for health care or other services.
So refugees losing access to health care is a success?
We do not believe that individuals who should come to this country to be dependent on public welfare programs. That's the basis for that. Which
so,
is
sir,
the DHS rule.
you have frequently told the story of your grandfather arriving at Ellis Island from Lebanon as an impoverished teenager who spoke no English. You talk about him being met by a member of the United States Public Health Service. You speak proudly of that story. Under this rule, based on your own telling of that story, your grandfather would have been turned away. So I ask you, yes or no, are you proud of this public charge policy?
So my grandfather came and worked his way up through his bootstraps in
Would
the
he have
steel
done
mills of Bethlehem.
Would he have had access to health care under this policy?
No, he would not have.
And
He wouldn't have asked for it because he would have wanted to make his own way.
And so you are proud of this policy?
I'm proud of my grandfather, and 100 years ago he came to the United States at Ellis Island.
That was not the question.
We
Are you
support
proud of this
this
policy?
It's we
gonna take
believe
that
the
as a no.
American people don't support the idea that people should be coming to this country to be.
Mr.
on
Secretary,
public welfare.
next question. Are you aware that under your leadership, the number of Americans without health insurance has risen for the first time in a decade in 2018 by roughly 2 million people?
So actually, the numbers on the uninsured require a bit more depth than that. What's happening on the uninsured is actually the ACA has most of the growth of uninsured is because the ACA priced individuals out of the individual market.
Sir, I'm not
2.5 million
going
are
to
in
let
that
you
coverage
take my
gap, and
4 minutes.
1.9 earned too
Are
much.
you aware, sir, Mr. Secretary, that the percentage of uninsured children rose by 0.6% under your leadership? And would you consider fewer children with access to health care a success?
So actually, in terms of children and coverage, we have S-CHIP. We've reauthorized that for a long period of time. We've got the Medicaid program.
You can test the numbers.
So in terms of the uninsured numbers there, if the children that are uninsured are likely part of the coverage gap left by the ACA, as well as the pricing out of
And so, sir,
non-subsidized
do you believe
individuals.
it's so last month, we held a hearing here about an opioid epidemic where a representative from the Department of Health and Human Services of North Carolina stated that if North Carolina had expanded Medicaid, 415 more people would be alive in North Carolina today. Do you believe that this administration's opposition to Medicaid expansion, that according to that individual has cost lives, is that a good policy choice?
I am not going to validate that politician's statements. I don't know.
It was a representative of the Department of Health and Human Services of North Carolina.
I don't know who they are. I don't know the basis for that. I haven't seen the evidence.
So you're
behind it.
unaware of the fact that Medicaid has saved lives in North Carolina, or the absence of Medicaid expansion?
That's not what I'm saying. I'm saying I haven't seen the evidence basis for the assertions you're making and that he made.
One last question for you. You've spoken about this administration's efforts to combat coronavirus and the so-called increased choice for healthcare. For one man, Osmel Martinez, asked you. Those two things recently converged when he tried to be prepared after developing flu-like symptoms following a trip to China. He was left with a bill of well over $1,000 and a demand of proof that the flu he was tested for wasn't related to any pre-existing condition, or else he would be forced to pay a few $1,000s more. So please explain to me, as we are staring down a potential pandemic and the CDC is warning about fundamental changes to our way of life because of it, do millions of people that have signed up for junk insurance plans pushed by this administration, do they really have a choice?
So the short-term limited duration plans are an option for individuals. We've been very clear that they may be the right choice for some, but they may not be the right choice for others who have pre-existing conditions.
Leaving people with thousands of dollars of uninsured claims in the midst of a potential pandemic, that's a good choice?
So if an individual, if it's a choice between no insurance and some insurance, it's 60% lower than what the Affordable Care Act has priced them out of the market at. It's at least an option for individuals
Unless
that
they
the
expanded
ACA
Medicaid.
didn't provide.
Yield back.
The gentleman yields back. Pleasure to recognize the gentleman from Indiana, Dr. Bouchon, for his 4 minutes of questioning.
Thank you very much, and thank you, Mr. Secretary, for being here today. I'm going to switch gears a little bit. 340B is a critical program, especially for rural hospitals. And I'm just interested in what you think should be done, if anything, to continue to ensure that the 340B program, given its significant growth, is helping more patients get access to care.
You put your finger right on it there when you mentioned the growth. It has grown from $7 billion of pharmaceutical sales in 2012 to $19.3 billion in 2017. And we believe in the 340B program, but we do believe those savings need to actually make their way to patients, not just subsidizing hospitals, but actually make their way to patients. I mean, imagine, for instance, just take the issue of insulin. Hospitals often acquire their insulin at an extremely low price, but they don't have to necessarily pass those savings on to the patient that they're serving as an outpatient. That's partly why we, with Part B, proposed the changes and have tried to implement the changes that would reduce what seniors have to pay for Part B, would have to pay in the Medicare program for their drugs.
Do you think that more transparency in the 340B program would be part of the solution?
Absolutely. We support transparency in the program. We support giving me regulatory authority as part of our budget, and also requiring that hospitals that want to get the benefit of those savings I just talked about to retain that in the program would have to dedicate 1% of their work towards delivering charity care, which seems like a pretty low bar.
So what you're saying is probably that HRSA does need probably more authority and more teeth to
That's right.
address the program. Would you agree with that?
We need greater oversight, but we need regulatory authority to implement that oversight so that we can actually do audits in an enforceable way and have that type of transparency.
Thank you. I'd also like to thank you for making improvements in pain management a key component of the HHS opioid strategy plan. I mean, I firmly believe we'll never successfully address the opioid epidemic unless we also improve pain management, and I'm a physician, and patient access to non-opioid therapies, particularly FDA-approved medical devices, which have the greatest opioid-sparing potential. Can you tell us what HHS is doing to promote pain management best practices and the status of various provisions in the SUPPORT Act to break down barriers to non-opioid therapies for pain?
So one of my top priorities has been to leverage the Center for Medicare and Medicaid Innovations authorities to fight the opioid epidemic. And that's why we developed the maternal opioid misuse, or the MOM model. And we recently announced the participants in that model. And that's going to address the fragmentation of care for pregnant and postpartum Medicaid beneficiaries with opioid use disorder by supporting care coordination and better integration. So that's part of that.
Great. And earlier in the hearing, you were starting to give some bullet points on, I think, Corona, your plan, the 5-point plan or whatever, in the last 50 seconds. Can you expand on that?
You bet. First, expand our surveillance system so we have novel coronavirus surveillance comparable to what we have on the flu, because that's the bedrock of our public health response. Second, money to support state and local public health departments. They're going to have to do a lot of work here. Third, vaccine research and development. Fourth, therapeutic research and development. And fifth, finally, strategic national stockpile acquisition, especially of personal protective equipment.
Thank you for that. And do you feel that we've had enough access in China to get the data that we need to help solve this problem? Is that loosened up?
We have struggled. The World Health Organization, Gore and team, has now completed its mission. We're awaiting its report. The initial reports I have is that team felt they were getting access to information and evidence, but I want to see the final results of that.
Okay, thank you, Mr. Secretary. I yield back.
Gentleman yields back. Just for the record, HHS has existing oversight authority of 340B, and it's my understanding that ERISA has conducted 1,300 audits of the program. So
the courts actually have said we do not have the ability to implement regulations. So that and that
we're
without
not
those
talking about that. They were talking about audits, and so that's why I wanted to get this on the record. Look at your audits and see what's in them. It's under the control of your department. I now would like to call on or recognize the gentleman from California, Mr. Cardenas, for his 4 minutes.
Thank you very much, Madam Chair, and appreciate the opportunity for us to have this oversight hearing. Secretary Azar, thank you so much for being with us. This is an opportunity for us to ask you some essential questions in fulfilling our oversight duties. And last time you were here before us for a budget hearing, I asked you about your agency's role in the horrifying practices of separating children from their families. Today, I would like to ask you about other ways that the administration is impacting families, both in my district and throughout the country. I'd like to ask you about an issue that is frightening families in my own district. I'm, of course, talking about the for-profit company's proposal for a detention center in my district, a proposal approved by HHS and that wants to use our federal tax dollars to put a facility there to have children in a prison-like setting. Vision Quest, the company that received these funds from your agency, has a history of alarming reports and stories of abuse within their programs right here in this country. These stories include descriptions of excessive use of physical restraints and isolation, verbal abuse, food deprivation, humiliation, and intimidation, and even deaths. And this is all about them having children in their care. As part of the due diligence of your organization, would officials within the Office of Refugee Resettlement be aware of these types of violations before awarding a contract to such a company like Vision Quest?
I don't want to endorse the statements that you've made regarding that entity because I do not know the particulars of that entity or the allegations that are being made there. So I want to be careful that I'm not endorsing that. But
okay,
I would expect that it would be part of any grant review of any grantee to examine their past history, treatment of children. I would absolutely expect that, yes.
Okay, if you could please report to this committee if any of the grantees, such as the one that I was talking to, if there's any evidence within the department of any valid situations with an organization such as an organization that would be entrusted with federal funds to house children. Okay, sure. Thank you. But the funds, these funds that you'll be providing, unless you were to have such evidence, you would go ahead and contract with an organization?
Well, that's how, as you know, the Unaccompanied Alien Children program runs, is we hire grantees that run permanent, hopefully permanent, state licensed facilities that care for children until we can place them with sponsors. That's really what the system Congress set up. That's what we run.
Thank you. And the city of Los Angeles is in the process of solidifying their ordinance as to whether or not they're going to allow private entities to use federal funds to house children. I have another issue I'd like to discuss with you. I want to turn to the issue of impacting American families, especially vulnerable children throughout America. In your written testimony, you speak about the importance of promoting adoption to give children the stability and love during their childhood. You speak about prioritizing adoption, but you neglect to mention the fact that right now in America, the agencies are turning away qualified potential parents because they are either LGBTQ or they happen to be of a religious minority here in America. This is in spite of the fact that LGBTQ parents are 7 times more likely to foster or adopt children than non-LGBTQ parents. My question is, in your efforts to identify and address barriers to adoption, can you tell me how eliminating data collection and reporting on sexual orientation over foster and adoptive youth and parents is helpful to furthering that goal?
So the Afcars, what you're referring to, I believe, is the Afcars reporting system. And the original regulation contained 270 individual data points, 153 of which were new. And the states, there was significant feedback about just the sheer volume of data collection and expense to states, all of which is money that if we add more and more questions, more and more data collections, that's money the states can't use to actually assist with adoption and foster care placement. So it's really just an effort to streamline those data requests in there.
My time's expired, I yield back.
Is the gentleman yielding back? I thank the gentleman. Pleasure to recognize the gentlewoman, and that she is from Indiana, Ms. Brooks, for 4 minutes.
Thank you, Madam Chairwoman, and welcome, Secretary Azar. Thank you for being here. And thank you for pointing out that just this past June, the President signed PAPA, the reauthorization of PAPA, of which this committee worked very hard on in the last Congress, and we finally got it done in this Congress. I worked particularly hard with the chairwoman and the ranking member of this committee to try to make sure we improved our readiness and our response, and because the question of a pandemic is really not a question of if, but when. And I think most people, and obviously CDC is acknowledging that. One thing I'd like people who are listening to understand, the Global Health Security Index was recently issued, and the United States of America was first in the world out of 195 countries for prevention, detection, response, and public health. And also want to commend the administration for the National Health Security Strategy that was put in place for 2019 to 2022. I want to commend you for leading that work. But with respect to PAPA, I'm curious, how are you leveraging, how is HHS leveraging all of the new things that we put into PAPA? And then I have one I'd like to also ask you to address, because there are so many good things in your budget, but I am particularly concerned about a $200 million cut to BARDA, because BARDA has brought forth so many incredible innovation and the partnership that they have with the private sector. Given this proposed cut, what strategies are we going to put in place if BARDA is cut?
So on the BARDA question, so that was, of course, in the budget before the coronavirus situation. And because Congress in the appropriations in December added, I think, $535 million of Ebola funding available in 2020, we were pulling forward some of our acquisition strategies from BARDA into 2020 around especially vaccine and therapeutics on Ebola. And so that created some offset. We may need to relook at that now, given some of the offsets proposed in the supplemental request. But that was meant to be somewhat because we had pulled forward some of those acquisition strategies to 2020.
Okay, but the private sector companies who are our partners in developing the diagnostics, the therapeutics, the vaccines, and because the government is the customer for those products, is it fair to say then that BARDA and all of the BARDA professionals who are working in BARDA, is it fair to say that they should not anticipate with what is happening right now a cut in their funding?
We would work with the appropriators as to whether the offset we proposed on the 535 Ebola to be part of the funding of the supplemental, if that happens. I can tell you from feedback this morning at the House Appropriations Committee, think that may be unlikely from the
Because
appropriators.
we still have Ebola in
Yeah.
Africa, is that correct?
We do, although fortunately, it's definitely on the downswing on the epi curve at this point. But what we would do is use that money for acquisitions on Ebola, if that money remains there for Ebola in 2020 vaccines and therapeutics that we've got. But if not, we'd work with appropriators on making sure BARDA is adequately funded, certainly.
And are there any other issues or any other strategies or framework that we provided in PAPA that you are using specifically right now to combat the coronavirus?
On the coronavirus, I can't trace directly to the PAPA authorities, but for instance, our vaccine strategies are very much influenced by that in terms of recombinant DNA, the universal vaccine research that we're doing in the influenza case, as well as cell-based technology to bring domestic manufacturing capabilities here.
I yield back my time. Thank you.
The gentlewoman yields back. Just for the record, the gentlewoman asked about the $200 million cut to BARDA, and the secretary responded. The administration, Mr. Secretary, put out the budget 10 days after, not before, after declaring a public health emergency. So your answer is really not correct on that.
Well, I'm sure
And I
you
think
understand
it's-
the budget is locked in December, so it's already probably was printed by the date of the coronavirus outbreak.
Well, you mean the administration doesn't have the ability to call it in and cross something out and say, no, we're not cutting this, we need it? I mean, that's not, come on. All right, now, the gentleman from Vermont, Mr. Welch is recognized for 4 minutes.
Thank you, Mr. Secretary. I've been here a while. Drug importation, we're very happy that you're proceeding on that. And as you know, we have a Republican governor in Vermont who's extremely interested in getting authority to do this. And they hope to have everything that's required for you sooner than the deadline. So we think it's a great opportunity. Our Republican governor and Democratic legislature wants to take advantage of this. One of the concerns that the governor has in particular, but all of us, is including insulin, and that's not included. And my understanding is that there have been some concerns raised as to whether that can be safely done. It really would make a huge difference to Vermonters. And as you know, a lot of people already drive across the border to get insulin, and even some companies do that. Our view is that the concerns about safety are always legitimate, no matter where the source of drugs. But our real request is to accommodate insulin as one of the drugs that could be imported as long as it's done safely. I wish you could comment on that and tell us what we need to do to give some relief to folks that are desperate about the cost difference.
So unfortunately, insulins as an injectable product are expressly excluded under Section 804 of the Food, Drug, and Cosmetic Act, which is the provision for the Canadian importation regime that we're using. We have no objection to it. And in fact, the second part of the importation program where a drug company could bring a product in with a new drug code and actually price it at a lower list price so that they could deal with their PBM, those middlemen contracts that encourage high rebates. That's open for all products, including insulin.
So let me just understand, this is helpful. You're saying it's because of the statute?
Yes,
not because of a concern that HHS has?
It's the statute.
So as far as you're concerned, if you felt there was authority under law for insulin to be included, you'd see no reason to object to that?
That's correct. We would be supportive if the statute provided for that. We believe it can be imported appropriately, but the statute does not allow me to approve an importation regime under 804 with insulins in it.
So if we did an amendment to the statute to allow for insulin to be an exception, you'd be supportive of that, it sounds like.
I can't formally state an administration position, but I can tell you the president wants importation. He wants it yesterday, and we're delighted the governor is working because we want shovel-ready importations programs that when we finalize a rule that we could get to work on improving.
All right, so who would I follow up with in the administration? It probably sounds like you, but
Me.
you might have to talk to the president about supporting what statutory provision may need to be included in order to allow insulin to come in. That would be huge, huge, huge for the governor of Vermont and for the people of Vermont.
Happy to work with you on that, absolutely, and talk directly to the President with you.
All right, thank you. And I yield back. Thank you very much,
bet.
Mr. Secretary.
Gentleman yields back. The gentleman from Georgia, Mr. Carter, is recognized for 4 minutes.
Thank you, Mr. Secretary, for being here. I want to follow up on Representative Griffith's questions about DIR fees by the pharmacy benefit managers. And of course, as you know, the PBMs have squeezed out almost $4 billion out of pharmacies, out of retail pharmacies with these DIR fees. And a survey that was done by the National Community Pharmacists Association said that 58% of the independent retail pharmacists in this country don't expect to be in business in 2 years as a result of DIR fees, which of course should be of concern to all of us, but particularly to HHS and the delivery of healthcare services in our country. I just wanted to ask you, I believe you responded to Mr. Griffith by saying that the concern was the higher premiums with the insurance companies. As you know, 3 PBMs account for almost 80% of the market share in this country, and all of those PBMs are owned by insurance companies. How can we answer the question of whether those rebates that they are getting, the PBMs are giving, are going back to the insurance company that is also owned by the same company?
Well, that's one of the real problems we've got is we don't have PBM transparency. Absolutely. So we can't actually know where those monies are flowing.
It would appear to me that that's just taking money out of one pocket and putting it in the other pocket. I mean, it's the same company, and then it's extended even more than that to include the pharmacies as well. So, the vertical integration is something that's got to be addressed. But what do you think we can do to address the DIR fees? Now, the DIR fees have been associated with higher out-of-pocket costs for recipients, and that's certainly something we have to be concerned about, and I know you're concerned about, and you have said in the past that you are. But if we can lower out-of-pocket costs, would it help to have the rebates at the point of sale?
Oh, yes, it would help to have rebates at the point of sale that would lower out-of-pocket costs and pushing through, so folks understand the DIR is basically a penalty provision that the middlemen impose on the community pharmacist. But the patient is made to pay off of the full price when they buy the drug, and the pharmacy later may get this clawback of this penalty, but the patient doesn't get a refund of their out-of-pocket.
Absolutely, and that clawback can take place almost a year afterwards, and sometimes 2 years after.
Very unpredictable to the community pharmacy. They're struggling from this, absolutely.
Absolutely. Now, I want to switch to coronavirus, and these are yes or no questions, if you could answer them for me. At this time, are you and others involved in preparing for a potential COVID-19 outbreak, doing everything you can to prepare for such an event?
We are indeed.
At this time, if you and others involved in preparing for a potential COVID-19 outbreak felt like you needed more money, would you have asked for it?
I would have, and I have, and that request is there.
Okay. At any time, if you and others involved in preparing for a potential COVID-19 outbreak need more money, will you ask for it?
I will indeed.
Absolutely. So it's not as to say that the amount of money that is asked for is proportional to the effort that's going to be put forth to prepare for this.
Right. That's right. And the President has made very clear in my own discussions with him as well as publicly that we want to work with Congress on an appropriate supplemental appropriation here. And we've said, it quite deliberately says at least $2.5 billion. We want to work with Congress. We've got to get that money and make sure that the Congress is satisfied with the funding also.
As it should be the case. And again, and you find out that you need more, you're going to come back to us and we're going to approve it. We want you to have everything that is available that you need to prepare for this, and you're going to do that, correct?
That's correct.
Madam Chair, I yield back. Thank you, Mr. Secretary.
Gentleman yields back. Chair recognizes the gentleman from California, Mr. Ruiz, for 4 minutes.
Thank you, Secretary Azar, for being here today. As a father and a physician, I care very deeply about the physical and mental health of children, and also children while in the custody of the Office of Refugee Resettlement. And I'm glad my colleague, Tony Cardenas, brought that up because I'm also dealing with a similar situation in my district. ORR's website says their unaccompanied children program, quote, takes into consideration the unique nature of each child's situation, incorporates child welfare principles when making placement, clinical, case management, and release decisions that are in the best interest of the child. So let me get this straight, because definitely want answers. When determining appropriate housing for children in ORR custody, do you give grants to for-profit organizations with a documented history of child abuse?
Again, I can't speak to that particular grantee that was raised before. We would give grants to for-profit and nonprofit without discrimination.
So the
but we would-
caveat is those with a documented history of child abuse. I recently learned that in addition to the facility in Arleta, California, ORR is providing a grant to Vision Quest to open a 130-bed shelter for unaccompanied children in the city of Hemet, California, which I represent. Vision Quest is a for-profit organization whose history suggests that their focus is to make money rather than care about the well-being of children. This is exemplified by Vision Quest's very long history of keeping children in abusive and harmful conditions, which my colleague touched on. Dating all the way back to 1987, a report from the RAND Corporation found that, quote, the treatment methods used by Vision Quest were unorthodox, and that activities engaged in by the youth posed unnecessary risk to their health and safety. Last year, the Associated Press reported that in 1994, the Department of Justice documented episodes of physical and mental abuse at a Vision Quest shelter in Franklin, Pennsylvania, including staffers pulling children's hair, using harsh restraints, choking minors, and even slamming them into walls. And in 2017, the city of Philadelphia had to end a contract with Vision Quest after state inspectors found that staff members had choked, slapped, and injured children in the facility. Secretary Azar, providing federal funding to a for-profit organization with a long history of child abuse is definitely not in the best interest of children. Are you familiar with these reports?
I'm not familiar with all of those reports. Some of the allegations that you raised, I am familiar with. Of course, whether for-profit or nonprofit is not the factor, but we want to ensure that any grantee. Thank you.
A letter within the Department of Justice.
Thank you. I appreciate that. I appreciate that.
My question now.
Gentlemen, be seated and speak from the microphone so that what you say can be properly recorded.
Will do. So now,
As I just note from 1994.
Of course,
But we want to make, we will make sure
So
any
that's-
grantee is appropriate to the care
that's
of
why I
children.
mentioned a long history of abuse.
Well, we need to
And
make
so
sure that's correct and not
that's why
corrected.
when you look and review at these programs, I want to ask you, what is the process? Is there transparency? How do you determine and how do you open this up to communities to determine who's going to house children with the safety of these children in mind?
So for these permanent bedded facilities, which is our goal, at the request of Congress, the grantees would actually have to be state licensed. And so there's a state licensure procedure. That would be
Well,
the
the state of
community involvement.
Pennsylvania denied them their ability to take care of children because of those horrible.
And then they would not be able to be a grantee.
And that
in
they
that
had to
state.
close that facility. So the question is, when you look at those reports and you review the evidence, would you be open to reevaluating these grants and your relationship with Vision Quest
I will
in their
ensure
care
that,
for ORR?
I will ensure that ORR has looked at these, and this was part of the evaluation criteria in looking at them. Of course, just because an entity, as all of the behaviors you described, are absolutely unacceptable. I just want to be very clear about that.
And I'm glad you said that, because
Absolutely unacceptable.
The gentleman's time has expired. The chair recognizes the gentleman from Missouri, Mr. Long, for his 4 minutes. We really need to move along because we have another panel, and everyone knows it's a very important one. So let's stay on within our time. Mr. Long, 4 minutes.
Thank you, Madam Chairwoman. And Secretary Azar, I want to thank you for being here today. I know we tried to get together one time, and as soon as we sat down, my phone started blowing up that my house was on fire in Missouri, which it turns out it wasn't, but the alarm company people seem to think it was, and they sent the fire department. I'm sure you remember that. But I want to thank you for working so hard to advance the administration's health agenda on behalf of the American people. As you note in your testimony, rural Americans face many unique health challenges, and under your leadership, HHS created the Rural Health Task Force and is proposing a 4-point strategy to transform rural health, which is vitally important in my areas. I represent a lot of rural areas. Can you first speak to the Rural Health Task Force role in identifying the needs of rural areas and how to meet those needs department-wide?
Yes, absolutely. Thank you. The Rural Task Force identified 4 key priorities for us. The first, we've got to develop a sustainable model for rural health care. We can't just patch it over with money if it's not underlying economically viable. Second, we have to have prevention and health promotion in rural America. Third, we've got to leverage technology and innovation like telehealth. And fourth, we've got to get the next generation of providers out into rural America. And we've got to allow nurse practitioners and PAs to practice to the full extent of their license in rural communities.
Okay, thank you. And one area in rural health that's been seriously impacted over the last few years is durable medical equipment, as you're apprised of. I was pleased that CMS issued the interim final rule in May of 2018 that provided payment relief for durable medical equipment in rural areas and continued the relief in the 2019 end-stage renal disease final rule until the end of 2020. Can you tell me if CMS plans to continue this relief in rural areas after 2020?
So I'm not able, obviously, to discuss the pending regulatory action, but do know that that was a major priority to get that payment fix in place through the interim final rule to ensure better equity for rural America. So that remains very much top of mind for us.
Okay. And in the President's fiscal year 21 budget, there's a provision that would expand the competitive bidding program for durable medical equipment into rural areas in 2024. We have heard many complaints about the competitive bidding program over the years, really since its inception. Can you detail how you would like to reform the program and how it would impact rural areas?
Yes, what we would like to do in the budget is actually pay for durable medical equipment under the competitive bidding program and move that, though, from a single payment amount that's based on the maximum winning bid to actually paying suppliers on their own bid amounts, and then expanding the competitive bidding to additional geographic areas, including rural areas. We think that would actually enhance access to DME in rural areas by allowing competition there rather than simply having to depend on the payment results secured elsewhere. We think that can solve a lot of the access challenges that we saw that we had to work to fix with the interim final regulation.
Okay, and has CMS engaged with outside experts, economists, or consumer groups on this as it considers expanding the competitive bidding program?
We do. We engage with stakeholders and experts before we consider any new policy, and of course, the benefit when we do notice of comment rulemaking is to get that feedback. Would you go forward with the proposal without congressional approval? I believe for some of the regional elements on competitive business, I believe that I don't know if we require statutory authority. I want to get back to you on that as to whether the budget has that as an administrative action or a statutory request. If I could get back to you, Congressman, on that.
If you would, I appreciate it, and I yield back.
The gentleman yields back. The chair now recognizes the gentlewoman from Michigan, Ms. Dingell, for her 4 minutes of questions.
Thank you, Madam Chair. Thank you, Mr. Secretary. I know it's been a long afternoon. It's been nearly a month since you declared a formal public health emergency in response to the coronavirus global threat. On February 2nd, you sent a letter to Congress that you intend to use or transfer or reprogram authority to reallocate approximately $136 million from current programs. Yesterday, we got the details of those transfers, and I'd like to request the unanimous consent to enter that into the record.
So ordered.
Thank you, Madam Chair. These include $62 million transferred out of NIH, $37 million taken from the Low-Income Energy Assistance Program, and $7.5 million from the Centers for Medicare and Medicaid. Given that you plan to take $37 million from the Low-Income Energy Program, do we have any estimates of how many people that's going to impact and who are going to go without heat this winter?
So for the transferred reallocation authority, that works out to a 0.2% change, and we did that across the department evenly, but then within different agencies that they selected various programs. On LAHEAP, we are now late in the season, almost at the end of February. I don't have an analysis.
Can we get for the record, please, what we think the impact will be, because we obviously are worried about people who aren't going to have heat. You're going to take 60, and I just have to go fast. I have 4 minutes. You're going to be you took $62 million from NIH. Is that going to harm our ability to conduct medical research into new cancer treatments? I'm happy with you that opioid deaths have gone down this year. There's no one who feels stronger, maybe Annie, we're together, and meet other public health challenges. What's going to happen to those programs?
So the NIH, in doing the reallocation and taking their allotment of the 0.2%, they firewalled off certain priorities, including, I know opioid research and development is one of the priority
So it has
areas,
not been cut.
pediatric cancer, right.
All right. Now, I know you talked about this yesterday, but you stated in your Senate testimony yesterday that the U.S. currently has about 30 million stockpiled N95 respirators, which are masks that can help stop a person from inhaling ineffective particles, but that it might require 300 million for healthcare workers alone. This doesn't include masks, gloves, and personal protective equipment. That was yesterday. We've heard about nearly 900 more cases worldwide, 60 more deaths. Your own agency, I'm really worried, as I know the chair is, about the supply chain in this country. Your own agency has stated that 65% of N95 respirators are manufactured outside of the U.S., in China and Mexico. Yesterday, the Washington Post told us that our large group purchasing organization says we may only have a 2-week supply. I don't want to frighten anybody. We shouldn't be rushing off, but are we facing an imminent shortage of N95 respirators and other personal protective equipment?
So I did want to clarify on the numbers. I told the appropriators this morning this. After the hearing, I learned some additional information about the number of masks that we've got. We have a higher number, but the mix is different. So we have 30 million surgical masks, the gauze masks. We have 12 million N95 NIOSH certified masks, and then 5 that are not NIOSH certified, 5 million N95. So I just wanted to clarify the data on that. One of the things we're doing with the transfer money that we discussed earlier is contracting to get contracts started with domestic manufacturers of N95 masks so that we can scale up production.
But how long is it going to take to scale up that production?
It will take time because we do not have as much domestic
manufacturing. Is it a national security threat that 90% of our generics are coming from China? We've got this kind of shortage. What are we going to do, and I'm out of time, to help bring the kind of production of these kinds of essentials to this country so we're not dependent on anyone else?
Gentlewoman's time has expired. Who's next? No one on the Republican side? Okay. The chair recognizes the gentlewoman from Delaware, Ms. Blunt Rochester, for 4 minutes.
Thank you, Madam Chairwoman, and also welcome, Mr. Secretary. I have to express my deep concern and disappointment in the implementation of the Affordable Care Act, which is the law of the land. It appears that the Department of Health and Human Services has made it harder for Americans to access and afford the vital health insurance coverage that they rely on. Your department recently proposed a rule that would discontinue the ACA subsidies for low-income families who do not actively reapply during the ACA's open enrollment period. These are low-income Americans who are currently enrolled in $0 premium plans. Secretary Azar, your department's analysis acknowledges that there are 270,000 Americans who are re-enrolled in these $0 premium plans that would lose or could lose their coverage. And yet these proposed ending auto enrollment for these individuals, thereby endangering their coverage. First, a yes or no question. In deciding to propose this policy, did you consider the fact that it would result in American families losing coverage?
I want to get back to you for the record if I could. I don't know that we actually proposed it as opposed to ask for comment on whether one should allow auto re-enrollment for people that are 100% subsidized in the ACA exchange markets. I think we asked just for comment on that as opposed to proposing that as the approach.
So I'm assuming if you're asking for comment, it's something that you're considering?
It's under consideration if we should require someone to apply who's getting 100% of their subsidy paid for, their premiums paid for, should they affirmatively demonstrate that they continue to qualify on an income and wealth basis for that. as opposed to just rolling over and then pay and chase later if we find months later they don't qualify.
So can you guarantee that no individuals would lose coverage as a result of this policy?
Well, if they don't qualify, then they wouldn't retain coverage at 100% subsidy.
Meaning if you change the policy, then they wouldn't qualify and then they could
shouldn't
lose.
qualify.
I'm particularly alarmed that your department would propose such a policy given that Congress statutorily directed you to establish automatic re-enrollment for all individuals enrolled in the marketplace. That provision was signed into law by the president at the end of the year. This proposed policy goes against congressional intent. Mr. Secretary, will you commit to the American people that you will not take any action that would cause American families to lose their health insurance? That's just a yes or no.
I believe that rider was with respect to 2020 monies, and the request for information was regarding the 2021 plan year, which is not subject to that rider, is my understanding.
The deep concern is that the department now has a record of refusing to properly invest in robust advertising and outreach. The department has drastically reduced funding for outreach and education activities. It's gutted the Navigator program, limited the time for enrollment, and is giving consumers less opportunity to make informed choices. Now the department threatens to disclose American families' subsidies, to discontinue American family subsidies who have become accustomed to being re-enrolled every year. Mr. Secretary, would you commit to working with me to ensure that Americans wishing to enroll in coverage will be well informed about the opportunities to enroll?
Well, I'm always happy to work with you, Congresswoman.
Well, we've talked about working together before, so I just want to put it on the record on this particular issue.
So we, just in terms of open enrollment, we put out 1 billion reminder emails. We had 6.
It's just a yes or no question because my time has expired. Yes?
Happy to work with you.
Okay, we will follow up. Thank you, Mr.
Gentlewoman's time has expired. The chair recognizes the gentlewoman from California, Ms. Barragan, for her 4 minutes of questions.
Thank you, Mr. Secretary, for being here today. As we have heard from you, our U.S. government has implemented aggressive measures to help prevent the spread of the coronavirus. There have been repatriation missions, there have been travel bans, airport restrictions, and additional travel notices issued. Many of these actions have impacted Los Angeles County, and in particular, my district. On February 2nd, the President signed a proclamation banning foreign nationals who've traveled to China in the preceding 14 days and were not immediate family of U.S. citizens and permanent residents. Over the course of a few weeks, 808 U.S. citizens were flown back to the United States, where they were quarantined for 14 days at military bases. As of today, 37 countries have confirmed cases of coronavirus. Should we expect travel bans from countries like Italy, who have confirmed cases of transmission but are on a different continent than current travel bans? Mr. Secretary, how sustainable are quarantine and travel restrictions in holding the coronavirus at bay?
It's an excellent question, and that's why when we did the initial 212F China ban that you mentioned, we were very clear we can't hermetically seal the United States off, and at some point there would be sufficient spread in other countries that measures like that would not be effective. With China, of course, with the epicenter being in China and with the aggressive measures taken by China, that's what we felt it was appropriate to do there. We'll constantly look at other travel advisories, 212F restrictions, or surveillance and requests for home isolation as we gather more information. But it's a very fair point. Absolutely.
And so following up on that, what resources are going to, what resources are going to the quarantines that are happening?
So,
and should these be expanded? Should they be extended? What additional resources do you expect are going to be necessary?
So I would actually like to get us out of the federal quarantine business, and I do want to commend California and the local governments there. They've really been a superb partner with us on the repatriation of American citizens. But it is quite expensive to maintain institutional quarantine. We don't envision further repatriation flights. That really has implicated that need for us to scale up this type of facilities-based quarantine. In the future, as I think Dr. Schuchat mentioned yesterday, we'd envision more self-home isolation activities, state and local-based monitoring and quarantine activities.
Okay, I want to drill down a little bit on this, because on Monday, HHS issued a statement that revealed a naval base in Ventura County, Point Mugu, may receive American travelers coming through LAX who would be quarantined to be monitored for symptoms of coronavirus based solely on their travel history. Let me repeat that, based solely on their travel history. Mr. Secretary, what are HHS's plans to quarantine Americans based on solely their travel history? And would those be voluntary or mandatory?
So that would be the Hubei province travel. So an individual who within the previous 14 days has been in Hubei province in China as an American or a permanent resident alien or family member would be subject to mandatory quarantine. We're seeing very, very few of those individuals. I think we had a family of 3 and then 1 individual are really all I believe that we have right now currently in quarantine. So that's more of a backup concept there, the Ventura facility you're talking about, to know it's there. But we've, again, worked very well with the state and locals in California.
Right, and we certainly know that the CDC has said that's not a matter of if the virus is going to spread, but a matter of when. You know, Congress wants to work with your agency to fund adequate and effective and sustainable public health responses. We can't do that without sufficient funding going forward to appropriate to state and local partners. I know that you'll be seen out of the Congress, especially out of the majority proposal on that. Thank you, and I yield back.
Gentlewoman's time has expired. The chair recognizes the gentlewoman from New Hampshire, Ms. Custer, for her 4 minutes.
Thank you, Madam Chairman, and Secretary Azar, thank you for appearing before our committee. There is a lot going on, both in your budget and with our concerns about the coronavirus, so I'll move through this quickly. The key to a public health crisis, as you well know, is trust and credibility, and my point is it would be helpful for clear, easy-to-understand, credible updates from this administration to both us as policymakers and members of Congress and to the American people. And it would be even more preferable if the statements by the President of the United States did not contradict the statements of the scientists and physicians at the CDC and in your department. My time is limited. I want to jump right in on the administration's continuing efforts to undermine the Affordable Care Act's consumer protections for people with pre-existing conditions. The administration, and your testimony today, claims to support for protections for pre-existing conditions, but with all due respect, the facts speak for themselves. This administration has repeatedly taken action, including court proceedings, to undermine protections for people, including my constituents, with pre-existing conditions. Your department finalized a rule to expand junk plans that do not provide protection for people with pre-existing conditions and issued a 1332 waiver guidance creating new standards inconsistent with congressional intent. The guidance allows states to increase consumers' costs, reduce coverage, and undermine protections. Simple yes or no question, Secretary Azar, are you aware that the 1332 guidance could substantially raise costs for Americans with pre-existing conditions?
Actually, our 1332 guidance allowed me to approve reinsurance waivers for 11 states, causing 10 to 30% declines in premiums in the exchange market.
And in the other states, what would the result be?
One other state was, I think, I forget if it was Hawaii, that we approved a waiver allowing them to not have the shop. I think that was, if I remember correctly, was it Hawaii? Yes, in Hawaii. So that was at their request to not have the state. I forget the exact terminology of what the shop is, but it's a technical aspect of the Affordable Care Act. We've approved no other 1332 waivers at this point.
And will you commit not to approve waivers that would jeopardize the health and well-being and the financial well-being of Americans with pre-existing conditions?
You can't waive the protection against pre-existing conditions under 1332 or otherwise.
And this administration is inviting states to make changes to the ACA subsidy structure and direct taxpayer dollars to junk plans, and those do indeed threaten and jeopardize individuals with pre-existing conditions. Yes or no, do you think it's appropriate to allow states to direct taxpayer dollars toward junk plans that do not provide protections for pre-existing conditions?
We think it's appropriate to allow states to support access to these short-term limited duration plans, which are plans that the Obama administration allowed to 12 months up until the end of the administration.
Let me dive right into that. under the Obama administration, the short-term limited duration plans were for just 3 months. You've now extended it to 12 months with 3 renewals. That's not the same condition?
I'm afraid that's actually not correct. The Obama administration had them for up to 12 months up until the very end of the administration when they passed a midnight regulation shortening it to 3 months.
To 3 months, that's my point.
Right at the very
So
end. They were perfectly fine with it.
My point is
throughout.
it was 3 months, and you have allowed for extensions for up to 3 times. That is 4 years. And we had people testify here that they did not even have notice that their pre-existing conditions were not covered, and even insurers that said to them that if they didn't know they had a pre-existing, that they should have known. So this is something we need much more work on. I am to protect consumers with pre-existing conditions. Thank you. I
One
yield
correction,
back.
it's 12 reinsurance waivers, not 11.
The gentlewoman's time has expired. The chair recognizes the gentlewoman from Illinois, Ms. Kelly, for 2 minutes. And I just want to instruct the members, we have 2 more to question, and they've agreed to limit their time to 2 minutes each. We will then take a very short break, maybe 5 minutes, to reset the witness table for the next panel and allow the secretary to take at least a few-minute break. All right, so now we'll recognize the gentleman from Illinois, Ms. Kelly, for 2 minutes.
Thank you, Mr. Secretary, for being here. I wanted to talk about 2 issues that I've paid a lot of attention to and have actually ravaged communities of color across the nation. One is maternal mortality, and the other is gun violence. President Trump has expressed concerns about maternal deaths, and following mass shootings last year, he called for bipartisan solutions to reduce gun violence. But we in Congress have come up with bipartisan solutions for both. I've worked with my colleagues on the other side of the aisle on a bill to expand Medicaid to provide postpartum coverage for a full year, and Congress appropriated and President Trump signed into law $12.5 billion in funding for the CDC to study gun violence. Yet, your administration seeks to slash funding to and block grant Medicaid, implement more restrictive eligibility criteria for Medicaid recipients, and completely zero out funding for gun violence research. Secretary, are you aware, yes or no, that the budget contains a proposal that would allow states to impose an asset test on pregnant women in Medicaid? It's pages 112 to 113 of the HHS budget in brief.
I'd want to look at that and get back to you on that. I'm not aware of that particular provision.
Okay.
We do have the proposal, similar to what you just mentioned, for Medicaid that would allow states an option to cover pregnant women for 1 year after birth if they're suffering from substance use disorders. That's another part of the maternal mortality initiative.
Yeah, that proposal would cut Medicaid's funding by $2.2 billion. That's because it would cause a lot of people, including pregnant women, to lose their Medicaid coverage. So maybe you can't answer.
So that's a spending provision. The one I just mentioned, it would actually expand. Right now, they can only get 60 days coverage postpartum. This would allow that coverage for up to a year as a state option in a non-budget neutral way, I believe.
Well, my time's up. So.
Gentlewoman's time has expired. That legislation that we took up here is awaiting floor approval of the gentlewoman has been a leader on this for long before the rest of the members even knew that we had this horrible statistic in our country. Last but not least, the gentlewoman from Florida, Ms. Castor, for her 2 minutes.
Thank you, Madam Chair. Mr. Secretary, the administration is urging the federal courts to strike down the Affordable Care Act in its entirety, including the protections for more than 130 million Americans who have a pre-existing health condition. I think my neighbors back home would want me to relay to you how dangerous that is, how angry they are about it. They do not want to return to the days when insurance companies could discriminate against them if they had asthma, a cancer diagnosis, some other pre-existing condition. They don't want to return to the days where an insurance company can cancel them if they get sick. And I think the coronavirus now highlights the importance of consistent health insurance coverage that has a floor of essential health benefits, and it really shines light on these junk plans. The Your department has finalized a rule to expand the short-term limited duration junk plans. They're not required to cover pre-existing conditions. You acknowledged that in your last budget hearing in front of this committee. And a couple of studies have come out recently, a Georgetown Health Policy Institute study, one commissioned by Leukemia and Lymphoma Society that kind of highlights the abuses here. Is the department conducting any oversight on the abuses of these junk plans, the abuses in marketing, false promises? Are you conducting oversight of these?
So the short-term limited duration plans are off exchange, and so we don't
Could you just say
actually
yes
regulate.
or no quickly, 'cause
we don't
the time is short.
We don't regulate them directly. They're subject to state insurance regulation.
You do not, so you're it's like hands off. You said, we're going to promote these junk plans, and you're not conducting any oversight. Is that true, yes or no?
They are subject to state insurance regulation as individual
And you don't
markets
check
should
in with
be.
the state and monitor the abuses in the junk plan market that are
don't.
raising costs on everybody and excluding pre-existing conditions?
So we
Thank you.
we do
That's-
not regulate state insurance commissioners.
Gentlewoman yields back. Let's take a 5-minute break, and the staff can reset the witness table, and then we'll resume. Thank you.
Hey, so good to see you again. Sorry, my double.
I get it. Thank you. Okay.
Here's the.
The Subcommittee on Health will come back to order. What we're going to do is, we're not going to have our witnesses do their formal public statements. We have them all in the record. We thank you for them. I've actually read them, and I'm sure my colleagues have as well. What I just want to do quickly, out of respect to each, is to just give a quick introduction, and then we'll go to members with their questions. And first of all, thank you for being here. I think that the United States of America is so blessed to have, I think, the finest public health professionals in the entire world. And the world, there's a reason why the world looks to us, because we have you and your expertise. So, Dr. Fauci, thank you to you. We just, America can't live without you, really. Dr. Hahn, welcome to you. I think this is the first time that you're before the committee, and we'll make it really pleasant for you. We won't do to you what we did to the Secretary. Mr. Secretary, welcome back to the table. Dr. Kadlec, welcome to you. And to Dr. Redfield from the CDC, thank you for being here, and thank you for collectively for what you've done to help to brief the Congress during this. Now, is it my turn to ask? Yep. Okay. Let me start with the, obviously with the coronavirus. I started out earlier today saying that confusion is the enemy of preparedness. I do not put confusion at the doorstep of Dr. Fauci, Dr. Hahn, Dr. Kadlec, and Dr. Redfield. I think that you have done an excellent job in advising, briefing the Congress, and for the work that you're doing. I think we have some problems with the administration because the professionals say one thing, and then there's confusion on the other side. I hope that something else will happen too, and that briefings be held in public so the American people can hear you. I hope as we move through this challenge that the American people will come to know you the way we do, and that we elevate the level of confidence and trust that I know you can engender, but I don't think it's there now. There's confusion. Markets are roiling. It's not only because of confusion, but there are many matters at hand. But you, the scientists, the doctors, the American people couldn't be better served. They just couldn't be better served. So thank you to you for your especially important service right now. What I want to get to, Dr. Hahn, let me start with you, is our drug supply. Are manufacturers being forthcoming with the FDA about potential shortages?
We're being, Madam Chairwoman, thank you for the question. We are being very proactive in our discussions with manufacturers. As you know, drug manufacturers are required to report to us when there are potential disruptions.
And how far in advance do they let you know that there will be a shortage?
Typically, those conversations occur in real time. What we've done
I know
is...
that, I think usually all of our conversations are in real time. I'm saying how much, in a trajectory of time, if they were talking to you today, would they be able to tell when the shortage would begin? How much runway do we have?
We often do not...
Example, China and manufacturing. So we have a problem with that.
So just as an example, I can tell you that drug manufacturers are required to tell us when there's a potential disruption to the drug supply. When the applicants apply to the FDA, they might provide, for example, 5 different manufacturers for the precursors to the drug, and then 5 manufacturers for the actual final drug form.
Let me ask you this. If the coronavirus outbreak is continuing 3 months from now, and I pray that it isn't, what do you estimate the American drug supply will be? Have you done
we have looked at this.
Forward-leaning
There are 183
planning?
prescription drug manufacturers in China. 20 are sole source from China. That's both precursors as well as the final drug form. We've reached out to all of these manufacturers, and we have no shortages to those sole source drugs. It's the redundancy, Madam Chairwoman, that's most important. And if we have redundancy, then we can shift to other manufacturing sources.
The FDA, yesterday the FDA said, you mentioned this, the 20 drug products that are either solely sourced there for their active ingredients or finished drug products from China. Can you share that list with us, or is that proprietary?
That's a proprietary list. We are internally compiling lists associated with all the questions that we've been asking of manufacturers.
Dr. Redfield, how many coronavirus tests can the U.S. conduct as of today?
How many cases?
Yeah. How many tests can our country conduct as of today?
I would have to get back to you with the exact number.
Okay. I kind of teased, but I was serious, Secretary Azar. We have some deep cuts to these agencies, the people that you're sitting with. And it was mentioned by, I think, the ranking member that the budget was printed and it couldn't be changed because of the print and all of that. I think, Secretary Azar, the $200 million in cuts at BARDA, $700 million in cuts at CDC, and $3 billion out of NIH. Are you willing to reconsider that, given what our country is facing and what the American people need day in and day out from these agencies? They are the essentials.
The proposals to the budget do not impact our ability to do the novel corona response. The CDC budget actually has a $135 million increase in the fields of infectious disease.
Do you think that, in other words, they deserve these cuts? These are healthy cuts. This is good for them, and it's good for our country.
You asked me about impact related to novel coronavirus. These will not impact functioning related to that. And of course, we have the emergency supplemental request on top of that.
Well, but if you wrote it in December, how do you know that?
Because the changes that we make in the budget are not related to categories that will impact our ability to do the novel coronavirus response.
So there's nothing to reconsider?
I don't believe there is in terms of the existing budget proposal. We have
Well,
the
you
emergency
know what?
supplemental
It's,
adding to accounts that we think
Today
are
is
the relevant.
February 26th, 2020, and I certainly hope you're right. But I think that we're shortchanging the American people. This time to recognize Dr. Burgess, the ranking member of the subcommittee.
I think the chair, I would just point out, we are the United States House of Representatives. All spending bills originate in the United States House of Representatives, so it's certainly well within our power to provide the level of spending that you all request. The House is just now doing its budget, several months after the administration did its budget. I will be testifying to the Budget Committee tomorrow. I think if people have concerns, they ought to bring them up to the Budget Committee. I just hope we will actually have a budget debate and vote on a House budget, because we haven't in several previous years. But I do want to thank the panel for being here today. This is critically important. The chair is correct that people do need to see, and this needs to be public. That's why we have hearings, because hearings are on the record and are public, which is why several weeks ago I suggested we have this hearing, and I'm glad we're having it today. Secretary Azar, you were testifying on the budget before. You did take some questions on the issue of the Office of Refugee Resettlement. Just off the topic of Corona, can I say I have been fortunate enough to visit a number of your facilities provided by Office of Refugee Resettlement, and I think we are fortunate to have the men and women who are working in those facilities, and would you just please convey to them my thanks, because I do think they do a good job, and we would be much the worse without them.
I will, and that will mean a great deal to them. Thank you.
Dr. Hahn, you and I had talked a little bit somewhat earlier about the supply chain and the active pharmaceutical ingredients that we import from overseas, and the fact was that there was an adequate stockpile as sort of this story began to evolve several weeks ago. What or to the extent that you can tell us, how are things looking now as far as the stockpile that companies have available, as far as the active pharmaceutical ingredient?
Thank you, Representative Burgess. As we discussed before, we've received no reports of shortages and found no shortages in prescription drugs coming from China. And we have discussed this with manufacturers and pharma companies, and adequate supplies currently exist.
So can I just offer this observation, since, and I've been on this subcommittee for a long time, and we've had this discussion in other guises in other times. And if there's ever any silver lining to this cloud, it may be that we recognize that we need to bring some of that manufacturing back within our own shores, so that we're responsible for we have the responsibility for that, for those active pharmaceutical ingredients. And I know this is something the president is focused on, and part of his rebuilding of America. This is, I think, work that this subcommittee has done in the past. I think it's something that we really need to take very seriously. We had some hearings on continuous manufacturing a few weeks ago, and I think that is another aspect of this where perhaps some attention to the continuous manufacturing, but the main thing is make it here, so we're not dependent on a sole source from another country, whether it be in difficulty from an infection or just simply out of sorts with the United States at the time. It does jeopardize our people, and I do think we need to recognize that. And again, that's not a criticism of this panel. We have known about that on this subcommittee for a long time, and it's just we haven't acted. Now perhaps we will. Dr. Redfield, I would like to ask you, and we've heard several times, the World Health Organization was able to finally get into China and assist them, and now that report is going to be coming back. Are you satisfied with the level of interaction that you've had with your Chinese counterparts? Because the CDC itself was not allowed to go in. Is that correct? It was only as part of the World Health Organization?
We were able to have a representative on the Gorn team that went to China to do the investigation. I've had regular conversations with my counterpart, the head of the CDC in China. We've had good exchange of scientific information. We do have a CDC office in Beijing, China, that's there, and they continue to have good interactions with those colleagues.
So you think there is working with the state and local folks?
There's good scientific interaction between us.
And Dr. Hahn, let me just come back to you for a moment and thank you for the the work you're doing on getting a laboratory-developed test, that is critical. They can't all be done at the CDC. We're going to have to be able to get those tests done rapidly in the field for our people on the front lines. But to the extent that, is there any evidence that there's any sort of hoarding behavior going on with things like personal protective equipment or pharmaceuticals? Is that something about which we need to become concerned?
In terms of the supply for,
Yes.
yeah, we have reached out to manufacturers, and we're aware that spot shortages can and have occurred. However, currently we know of no overall shortage related to PPE. However, this is a very dynamic situation, as I mentioned at yesterday's press conference, that we are likely to see some pressure, particularly on the demand side here.
Is there
We're
anything
working very closely with manufacturers on this.
Okay, is there anything you can do to prohibit or prevent, not prohibit, but prevent hoarding activity by people who might just be buying up equipment?
Well, the department has led an all-department effort to communicate to providers and hospitals regarding this issue, and we have recommended following CDC guidelines with respect to the use of particularly respirators, where it seems to be the most pressure.
Okay, thank you.
Gentleman's time has expired. It's a pleasure to recognize the gentlewoman from Colorado, Ms. DeGette, for her 5 minutes of questioning.
I thank the chair for including some of the other subcommittees in this. As 4 of the 5 of you well know, that we've been having hearings in the Oversight Subcommittee for years on these issues. It's what keeps me up at night. The most recent hearing we had was on December 4th about seasonal flu and pandemic flu. And lo, here we are. And what I'm concerned about is we're still not any more prepared than we were on December 4th. And so that's what I want to talk about. Back in 2005, we had a national blueprint for biodefense, or 2015. Some of you recognize this document. Our now colleague, Donna Shalala, had your job, Mr. Secretary, and in this blueprint for defense, what they did was they said, we need to have it, in case we have some kind of a pandemic, we need to have a clear line of authority to make these decisions. Are you aware of that, Mr. Secretary?
I wasn't aware of Secretary Shalala's recommendation in
But
that
are you
blueprint.
aware of this blueprint?
I'm aware of the blueprint. I wasn't aware.
Okay.
I wasn't
Well,
remembering that recommendation.
So this is what I want to ask you, because I just got back from Japan on Monday, and so we were really looking at the Diamond Princess incident, and here's what I was concerned about is you had all these people sitting in this petri dish of a ship for a long time. The CDC said that people should not be flown back to the U.S. from that ship. And then apparently the CDC was overruled by the State Department. So here's my question. You're the chairman of the President's Task Force on the novel coronavirus. Who's in charge? Are you in charge?
I'm in charge, but in Japan, the deputy chief of mission, who is the charge d'affaires, who
Right.
made that decision, has full authority of the President of the
Right.
United
So
States
that's-
in a foreign country.
That's the problem.
No, that-
Well, yeah, it is, and I'll tell you why that's the problem. Because you're the head of the panel. The health experts are saying you shouldn't be flying these people back in, and then there's another agency that basically overruled what you said. If we have an outbreak in the United States, there are a number of other agencies that are going to have other interests. And I'll just give you a couple of examples. The State Department, which we just dealt with, HHS is you, the state public health departments, various other agencies. Who is in charge of the final verdict? Is it you?
It depends on the circumstances.
That's not gonna work if
it's in a foreign country, the ambassador of the president is the final word on representing the United States interest in that country.
So what happened is they flew back in 14 Americans, maybe more, who were infected with the coronavirus. That's why someone needs to be in charge. And you know what? I think it should be you.
I just, with respect, the deputy chief of mission had a very difficult decision to make there.
I understand that. I don't need you to explain that to me. What I'm saying is this goes along, there needs to be someone who can overrule Homeland Security and state who can make these decisions for the American public based on public health. And I'm hoping we can have some more hearings to talk about that. Dr. Redfield, I want to ask you, because the Chairwoman Eshoo asked you the question about the lab tests, and you didn't know, you said you didn't know how many lab tests are available. Do we have lab tests that will accurately test for the coronavirus?
Yes.
Okay, now what I heard was they're limited, and people have to send their test to the CDC to be tested. Is that right?
Presently, there's 12 jurisdictions that have the test up and running.
12 jurisdictions throughout the United States?
Throughout the United States.
And so people can send their tests there?
And
when are we going to be able to put that everywhere?
Well, we're working cooperatively with
I'm asking you, when are you going to be able to put that everywhere?
I was trying to say,
know?
we're working with the FDA now. We're hoping that later this week, our test will be such that the first one can go, all the laboratories that got it can execute the current test on the modification that we did with the FDA.
Okay. Dr. Fauci, I know you're working on developing a vaccine. If we gave you more money, could we develop a vaccine more quickly?
We would need more money to take it for the next step. We're in a phase 1 right now, and we're okay.
How much more money? How much more money? I think you could probably get bipartisan consensus that would give you the money.
Yeah. How much would you need to get it over the hill?
Mm-hmm.
About 140 million.
140 million.
Right.
And if, Congresswoman, if you wouldn't mind, the emergency supplemental would actually dedicate $1 billion for vaccine. Just that's part of the detail we'll be working with the committee on.
Okay, I just want to say one more thing because my time is up. And I know that Congresswoman Schakowsky is going to ask you some questions about the supplemental. I just want to say that even Minority Leader McCarthy today said we need at least $4 billion. And we shouldn't be shifting money away from Ebola and other diseases into trying to deal with this coronavirus. We need to work on all fronts at once. And I thank you for your comment, and I yield back.
Gentlewoman's time has expired. The gentleman from Kentucky, Mr. Guthrie, is recognized for his time.
Thank you, Madam Chair, and thank you for all being here. And just so everybody knows, we've been having these meetings, if they're not been formal hearings, bipartisan with several of you over time. And I remember when we first started meeting about this, it might have been Dr. Fauci, I said I don't want to put words in your mouth if you didn't, but we are going to prepare for a pandemic. That's what the American people expect us to do. We're going to prepare for a pandemic. We're going to put things in place for a pandemic and hope and pray that it never comes. We're going to get ready. And as we prepare for it, people are going to see things, hear things, and maybe react that this pandemic is imminent when it may not be because we're doing what we're supposed to do. The other thing is, I know the White House and the administration needs to reassure markets and marketplaces where we are and where we stand. And for everything that I've heard previously and what Larry Kudlow has said is not inconsistent, is where we are. But I know that the CDC came out and talking about the pandemic to be ready for it. And Secretary Azar, if you'd like to explain this, I know the CDC warned that Americans should, and I'll quote, prepare for community spread in the United States and should be ready for, quote, significant disruption. And would you explain what that means, what it means to the average person, what that means, and what's the most important message you would like for the American people to know about the current state of America and the coronavirus?
Our messaging from the president through to the career officials at the CDC has been consistent, but it's striking a balance. America's risk is low at the moment. That could change quickly. We are working to keep that risk low, but we have always been transparent that we expect more cases in the United States with a rapidly spreading virus, especially with what we've seen. For the average American, there's no change in their behaviors except what we always would advise, which is practice good public hygiene, washing your hands appropriately, coughing into your arm, not touching your face with unwashed hands, and appropriate preparedness activities at home. And you can go to cdc.gov for normal advice for flu seasons, hurricanes, and others. Good preparedness, good thoughtfulness at home. We're trying to be very transparent to people of the risks we face. even if we're at a low-risk situation now, so that so people aren't surprised, so that they know what we're dealing with and what uncertainties we're dealing with.
Thank you. And so Dr. Fauci and Dr. Redfield, for 50 days, we've learned much about the coronavirus, but much is still unknown. What is the current, that's what I know people want to know at home, what is the current scientific consensus about the transmissibility, infectiousness of the virus, and how long, once you're infected, will you be infected, how long can you pass it on? And what are the other remaining known unknowns? What are the things you know that you would like to know the answer to with Dr. Fauci and Dr. Redfield, or Dr. Cadillac, if that's in your world?
First of all, we know it's a very transmissible virus. There are some viruses that are not efficient in going from human to human. What we learned early on, and we are convinced now, given what we've seen in China and other countries, that it's a highly transmissible virus. That's the first thing. The second thing, when you say how long a person is infected after they get infected, that's something that's still up in the air. And the way you get the answer to that is you try and isolate virus, what we call shedding, for a period of time. And we know that there are individuals who are actually able to transmit when they are without symptoms, before they get symptoms. What we don't know yet, and I think we're going to get information from the group, including the CDC individual and one of my people who was in China with the WHO group, what the extent of that transmissibility is from an asymptomatic person. Is it minor, part of the driving of the outbreak, or is it significant? That's going to be a very important thing that is currently an unknown. And Bob, you want to take up?
I concur with Dr. Fauci. I think the biggest challenge we have right now is what is the relative infectivity, whether before you get sick, are you more infectious before you get sick, or are you more infectious after you get sick? We are tracking these patients that we do have in this country to see how long they actually have a virus that can be isolated from their respiratory secretions. It's probably going to be longer than many of us originally anticipated. I think at this stage we have an individual's out about 18 days from the time they initially actually got sick. So I think these are key questions, and we continue to try to get the data to answer them.
So are there other things that you are looking to know that you don't know, that you know that you don't know, that you're trying to find the answers to?
Well, I think one of the other areas from the CDC's point of view is try to understand the methods of transmission. Is it all respiratory transmission through droplets? Is there fomite transmission? For example, can this virus survive on certain surfaces long enough for somebody else to come down, put their hand down, and then touch their face? It's not clear right now what the relative components of, say, droplet transmission is to fomite transmission.
Thank you. My time's expired. I'll yield back.
The gentleman yields back. Where are we? Oh, I see. The gentlewoman from Illinois, Ms. Schakowsky, is recognized.
Thank you. As all of you know, the World Health Organization has declared the coronavirus outbreak a global health emergency, and our administration now has declared it a public health emergency. Yet, Secretary Azar, we've talked about this, you've heard about it. The Trump administration asked Congress for just $2.5 billion to combat a disease that the CDC's director, Nancy Messonnier, warned could severely disrupt daily life and could severely and could cause severe illness in the United States. So in that request, you did not, as I understand, include, were not specific about surveillance for testing kits that actually work, because not all of them have, and for treatment. Instead, you suggested robbing $500 million from the United States response to Ebola epidemic, which actually still is raging in places. So I find it incomprehensible that you're asking for a molehill when what we really need is a mountain of support here. Secretary Azar, yes or no, do you agree with the President of the United States that the coronavirus is very much under control in the United States, unquote, and will, quote, go away, unquote, by spring?
He did not say the last part that you just said. He said, we hope it will go away with warmer weather. I hope everybody here would hope it would go away with warmer weather. The virus in the United States has been in a contained situation to date, but that can change. As Dr. Messonnier said, we expect more cases, and we expect that we will see at least limited community transmission of the virus in the United States.
Let me ask you another question. My hometown of Chicago reported the first human-to-human transmission of the coronavirus in the United States. And though the Illinois and Cook County and Chicago Departments of Public Health have expertly, I would say, handled over our two coronavirus cases, they have not received any reimbursement or financial assistance for the work they've done. I just met with the Director of Public Health in Chicago, who said they're spending $150,000 per week to respond to this. Will the United States be able, in the $2.5 billion, be able to help local and state health officials who have already spent lots and lots of money trying to deal with this?
So yes, that is actually part of the supplemental request, is to fund state and locals, in addition to the $675 million FEP money they already have received for many years. Illinois, of course, received each year $16.3 million for exactly these activities, but we want to give additional funding through the supplemental request for those activities.
Well, that's really good news. Thank you. Secretary Azar, will your $2.5 billion be enough to help healthcare workers in hospitals and nursing homes, or the home care workers who have to care for quarantined individuals?
In what respect are you asking?
Well, I mean,
salaries, because they're already paid. I'm just curious. I want to.
No, I mean,
if there are elements we need to add to our request, we'll be glad.
There may be a lot of
Congress
additional costs that people that work in hospitals, and they may have to hire more people. Is there any help that's going to be for staffing?
Would you mind if Dr. Kadlik responds?
I can address part of your question, ma'am, and that is $350 million is dedicated for personal protective equipment that could be used by healthcare workers in many different settings. So we have that, we're stockpiling that to make it available should communities need that, in addition to what they have on hand.
Okay. Let me just finally say this. Last week, 45 of my colleagues and I sent a letter to President Trump, and what we were talking about is, are we going to be guaranteed an affordable treatments or vaccines that are developed? We're concerned that private pharmaceutical companies may end up having a role in this and raising the cost beyond the point that people could well afford it.
We absolutely share your passion around ensuring affordable access to medicines, but the private sector must have a role in this. We will not have a vaccine, we will not have therapeutics without the private sector candidates that they and we will have to invest in.
But we have paid for all of the R&D so far, right?
No, that's not accurate. For instance, the Gilead has a product, remdesivir, that was originally NIH-funded basic research, I think, out of University of Alabama, but they've carried forward with development. Moderna is using Dr. Fauci.
My time has expired, but if I could just reaffirm, then you're saying it will for sure be affordable for anyone who needs it.
I'm saying we would want to ensure that we work to make it affordable, but we can't control that price because we need the private sector to invest. The priority is to get vaccines and therapeutics. Price controls won't get us there.
Mr. Secretary, thank you. I now recognize the gentleman from Michigan, former chairman of the full committee, Mr. Upton.
Thank you, Madam Chair. I've got a couple questions I hope to run through, and I guess the first question ought to be directed at, first of all, thank you all, 24/7, and for the briefings that we've had over the last couple of weeks as well. I guess this ought to be directed first to Dr. Redfield. There's a report just published now in the last hour or two. Apparently there's a daily newspaper in Korea called the Jungang Daily, and they reported that there is a Korean Airlines flight attendant who serviced a number of flights between LAX and Seoul, and she was confirmed to have coronavirus. She also, they're not sure where she got it. There's some suspicion that she had also worked a flight to Israel with that apparent tourist group that came from Korea there in the previous week. What do you know about this? Is there some communication? I hope you know something, but I know that it's recent news. But it was published Tuesday in Korea. It's Thursday now. So just wondering what you might know about this.
I can say that I haven't been briefed on that, sir. Normally what we would do if we had confirmed cases, obviously.
Now, this is a Korean woman,
Yeah, so.
24 years old.
Yeah, so that would be, we are interacting. We actually sent someone yesterday to embed in the Korean CDC to help facilitate communications between Korea CDC and our CDC. But I can tell you, I haven't been briefed on that specific situation, but I will look into it and get back to you.
Okay. Second, does anyone else know anything more? Dr. Fauci, I know that China did publish, thank goodness, the genetic sequence, which has allowed the rest of the world to try and pierce the bubble here. Moderne Therapeutics is one of the companies, I think they're out of Massachusetts, that is actually working on, I want to say a phase 1, but I may be wrong.
Yes.
Where, if it's successful, how long, what can you tell us?
We're working with the company Moderna on a vaccine platform called messenger RNA. We're working at our vaccine research center, and we did exactly as you said. As soon as the sequence was put on a public database, we pulled the gene out for the spike protein, which is the protein that you want to make an immune response against. There are several steps in that determine the success or failure of what you're doing. And we've been able to successfully express it in this particular platform that we're going to use for a vaccine. We have shown that it's immunogenic in mice, and very soon, within the next month and a half to 2, it's going to go into humans and as in a phase 1 study. But I think people need to appreciate, because there's often misunderstanding. A phase 1 study, we'll say, was 3 months from the go, which was about a month and a half ago. It'll take about 3 months or 4 to determine if it's safe and induces the kind of response that you would predict would be protective. Once you get there, it relates to the question that I was asked before, then you go to a phase 2 study. The phase 1 study has 45 people. A phase 2 study has hundreds or maybe even low thousands of people. That would take at least 6 or 8 months to show that it works. So from the time you push the button to go to the time you even know it works, it's about 1 year to 1.5 years. Then, as the secretary said, you have to partner with pharmaceutical companies to make millions and millions and millions of doses, which could also extend the time.
And that would be a vaccine or a
that
remedy?
Would be a vaccine to prevent infection.
Okay. Last question I have, and I'll save this for Secretary Azar. A couple weeks ago, my colleague Debbie Dingell and I sent a letter to the administration. You were copied on it as it relates to the supply chain of companies with operations in China, specifically Wuhan province. A lot of us are concerned about products that are made there. Auto State, Michigan, we got a lot of different things that are there. I know Apple, as an example. They fessed up, their stock price collapsed and led to the market trouble that we had this week. What type of outreach have you initiated outreach to companies, large and small, particularly on the shortage questions as well, because they may not want to tell you what they might know. So where are you all on that?
So as chair of the task force, we've directed a whole of government outreach to manufacturers and suppliers across not just healthcare, but everywhere. And Dr. Hahn and Dr. Kadlik have led the effort with regard to pharmaceutical, generic, and biologic and device manufacturers in China. And that's what Dr. Hahn was reporting on earlier, the results of that outreach. Very proactive. As you know, with drugs, they have to report to us potential shortages. Device, we don't yet have legislation on that, so we're proactively probing that system. As he reported, we don't yet know of any potential shortages, but we're on that because we share your concern about the risks there.
But just to follow up on, is Secretary of Commerce, are they working at other things,
Yes,
other than
yes.
beyond just drugs and devices?
Yes. With their regulated entities and their major manufacturing entities, they're working to gather information about potential shortages as they might impact the economy. The National Security Council, the National Economic Council are leading those efforts.
Thank you. Yield back.
I appreciate what Mr. Upton raised overall, but certainly the last part of it, the whole issue of our dependence on China, and that 90% of the American people take generics, and that those generic drugs are manufactured in China and to a lesser degree in India. But China controls the global market on the API, the active pharmaceutical ingredients. But I met with Dr. Kadlec after, I think it was the classified briefing. He came to my office. What I wanted to know was, do we have an inventory? Do we have an inventory of who the manufacturers are? Are any of these plants shut down? I know we asked questions about how long they can manufacture until they can't, and because drug shortages are a part of this whole problem with the supply chain. But when I met with Dr. Kadlec, we don't have that inventory. Is that in place now?
Actually, I believe
Mr. Secretary?
that's what Dr. Hahn briefed you on earlier.
We do have an inventory?
We have reached out to the manufacturers. We have to do that proactively because there are not requirements, for example, state of operations that are required to report to us.
But if we inspect manufacturing plants, don't we know who they are?
Yes, we do.
Do we have a list of them?
Yes, we do.
We do.
Yes, we do.
What's the difference between that and the question I asked then?
So we have a list of manufacturers that have been given to us by pharmaceutical companies who manufacture both precursor product and final drugs in China. But there may be 5 or 6 for each of these drugs, and they might be around in different countries.
I see. All right, the gentleman from Massachusetts, Mr. Kennedy, is recognized for his 5 minutes.
Thank you. I want to thank you all for being here. Thank you for being willing to be before this committee. I have some differences with some of you up there on our healthcare policy, but I'm grateful for your presence here, and I wish you all success. So good luck to you and good luck to us all. First off, a bit of just rapidly, sir, Dr. Redfield, if you can. I got a 2-year-old and a 4-year-old, and a lot of other parents of young children are nervous about this. Can you just give me a real quick question, a real quick answer as to, of parents of young kids, is there anything people should be doing at this point or should be concerned about?
Yeah, I want to echo what the Secretary said. At the current, right now, the risk to the American public is low. And we would argue that they go on with their life. Our containment strategy has been quite successful. But that said, what was said also is that we, in light of what's happened in Korea, Republic of Korea and Italy and Iran and Japan, and we've seen how fast this virus can move, we are encouraging people, again, to just think about being prepared.
Okay. Part of being prepared is trying to make sure that there's as much and as clear communication as to what we are confronting and how government is structured to be ready for this and to meet this challenge. I do think it's, obviously, some of my colleagues have noted that despite calls to strengthen our country's pandemic preparedness, this administration did dismantle the federal government's pandemic response chain of command, including leadership structure at the White House through the National Security Council's Global Health Security Unit. So when you flash forward to this year and the coronavirus starts spreading throughout the world, there have been reports of this task force, and Mr. Secretary, you indicate that you are in fact the head of it. I would ask, just if you can, to the greatest extent possible, communicate what that structure looks like so that people can have some understanding as to what is backing that up. You don't have to do it now, but just as you can, just to get that information out would be helpful to all of us. So moving on a bit, though, to try to make sure that there is not just a structure put in place, but that communication is in fact clear. Mr. Secretary, I would take a bit of an issue with the fact that the message is consistent. I think the message from you all up here, this panel so far, has been pretty consistent. I do have an ABC News story here that I'm going to enter for the record, which quotes the president from saying directly that it is, quote, a problem that's going to go away, end quote. The president is also quoted by saying, quote, the virus we're talking about having to do, a lot of people think it goes away in April with the heat, as the heat comes in. Typically, that will go away in April. We are in great shape, though, end quote. Dr. Fauci, does this go away in April with the heat?
The history of respiratory viruses such as influenza and other coronaviruses tend to diminish and almost disappear as you get into the summer. That's just something that happens every year. We see that with influenza. However, underline, however, this is a new virus, so we don't know what this virus is going to do. If it acts like influenza, the heat will actually make it diminish in its impact. But we have no way of knowing how it's going to act.
And I would say that there's...
Others are having...
Roughly, is that right?
Correct.
He had said, congressional staff briefed folks yesterday in a press conference, said, quote, "It's not a question of if, but rather a question of when and how many people this country will have severe illness." Agree that this is a problem that is going to go away without intervention?
I think it's important to recognize that from time to time, new pathogens come from animals and get into the human species. Clearly, this is one of those times when we've got a new respiratory pathogen that has come into the human species. And I think it's prudent to assume that this pathogen will be with us for some time to come. And
Dr. Cadlick?
As
Mr. Cadlick?
Tony said, we don't know the cycle of it. We don't know how it's going to, if it's going to be impacted by humidity and heat. But I think we should assume that this virus is going to be a virus that we're going to be challenged with, similar to the other viruses that we have that are respiratory.
Doctor, thank you. I've got 10 seconds left for the rest of the panel. Yes or no? Agree with Dr. Redfield. Mr. Cadlick.
I support Dr. Redfield's view.
Mr. Secretary.
The president's expressing confidence, this team, the public health infrastructure in this country, state and local, that we can deal with this. We will prepare for this. We will work together on this. He's trying to calm a public that we see in China, panic can be as big of an enemy as virus in these situations. And so there is always that balance.
Mr. Secretary, I don't want to panic over this either. The stock market's crashing. He's trying to stop a stock market. He's not trying, he's outright contradicting everything that you all have just said. Outright contradiction.
I think he's expressing confidence in...
With no medical basis for it. That's what you've just explained to us. Come on, sir.
He's expressing that the American people need to take a breath here, that there's no change to anyone's daily life from this, that the country has a plan. We have pandemic plans. There's a playbook for this, and we're executing against that. But we have to be realistic also and transparent that we will have more cases.
And sir, as head of HHS, do you agree with the president's statement as I quoted? The virus that we were talking about having to do, you know, that it will go away with the heat.
We gotta go. The gentleman's time has expired. Do you want to answer that quickly? No, I didn't think so. You're doing a great job for the president, Mr. Secretary. It's a pleasure to recognize the gentlewoman from Indiana, Ms. Brooks, for her time.
Thank you, Madam Chairwoman, and thank you all so very, very much for being here and for your work day in and day out on behalf of not only our country, but on behalf of the world. And I'd like to remind my colleagues that in November of 19, the United States of America was ranked #1 in global health security. A global health security index conducted by Johns Hopkins of 195 countries. We are leading the world. Now, that doesn't mean that we can't always continue to improve, and that's what PAPA, which was passed into law in June, did. It actually took care. It focused on vulnerable populations like children, like the elderly. We added a lot of new things to that. One of the things, though, that I am concerned about is the flexibility of the funding and whether or not we introduced an infectious disease rapid response reserve fund. $85 million was put into that fund. We have $705 million as strategic national stockpile fund. We have all of these. How much flexibility is there, or do we need to give you more authority, Mr. Secretary, very quickly, to have more flexibility to be able to not focus on Congress having to do supplementals all the time? How much more flexibility do you need?
Well, the Infectious Disease Rapid Response Fund has been critical for us. The flexibilities in the Strategic National Stockpile, critical to us. The emergency supplemental, the most flexibility that you could give us there as we deal with the situation as it evolves, we would appreciate that. Also, the challenge with setting up long-term funding mechanisms that are indefinite is they can become slush funds for any other priority as opposed to concrete, real public health emergencies. I think that's always been the challenge.
And if you find that you need more funding for any of these funds, will you come back and ask for more funding?
Absolutely, and I want to emphasize the 2.5 is at least 2.5. It's for 2020 only, and we will come back if we need more, and we will work with Congress if Congress wishes to give more.
Dr. Kadlec, with respect to the strategic national stockpiles, which I believe you oversee in conjunction with the CDC, is that correct?
Yes, ma'am.
What is the status of our strategic national stockpiles?
Well,
Can you quickly say what those are?
Sure, it's a variety of countermeasures that deal with chemical, biological, radionuclear capabilities, as well as for pandemic influenza. We have a supply of personal protective equipment that we have on hand. We have sent out a solicitation to get more, but the answer is we have a whole range of things.
And these are at undisclosed locations
Yes, ma'am.
throughout the country, are they not?
That's correct.
And at this point, is the strategic national stockpile sufficiently funded?
Ma'am, I think the thing is at this point in time, in light of what the requirements are, we've been given, at least in terms of what is in the supplemental request, another $400 million. That would be a great benefit to help us address any kind of shortfalls for this event.
Last week when I was home, I learned from a local public health official in Indiana that an individual from this county had traveled from China and, interestingly enough, had come through the Chicago airport. And the Chicago airport officials notified this public health official, said this person is coming home to quarantine, which I thought, and she appeared at this individual's home within 24 hours of that person coming through the Chicago airport. I thought that was awesome. It was excellent that that kind of coordination happened. How did that happen, and is that happening all across the country? And this individual is going to cooperate with the local health official, provide their temperatures for a couple of weeks. Is this happening all across the country?
Yes.
And how many do you have? Who at the airports is notifying local health officials?
So what happened when the original travel restrictions were put in for China and Hubei? If you were coming into the United States, American citizen or family member or a permanent resident, on Hubei, you were required to go into 14 days of quarantine. That quarantine could have either been institutional or that quarantine could have been in your home working with the health departments. And that's really how we've operationalized. But if you'd been from China, the requirement was that when you came through, you were screened, you were given an education card, provided you had no symptoms, telling you about the risk and what the symptoms are, and the contact information with your local health department. And you, in conjunction with your local health department, were going into what we called voluntary monitoring and isolation. And that woman that you gave the example did exactly as we instructed, and they were instructed as they went through Chicago O'Hare Airport.
And so actually, it was my local public health official that was incredibly impressed that she had received this information. The young man and his family are monitoring. Madam Chairwoman, I'd like to enter into the record CSIS produced a report in November of 19 about U.S. global health security, making sure we're ending the cycle with a number of recommendations. You and I serve on that commission. Would ask that that be entered into the record.
So ordered.
With that, I yield back.
Gentlewoman yields back. The gentleman from California, Mr. Ruiz, is recognized for 4 minutes. And for those that are left, there's an agreement that it's 4 minutes because the panel is getting nervous about time. So let's honor that. Okay? Thank you.
Thank you for being here today. I want to discuss a very important issue for local agencies, and I know many other members are hearing as well. That's funding and reimbursement for monies that our counties and public health departments have spent upfront to help fight the spread of the coronavirus. I'm a disaster-trained emergency physician, public health expert, and in disaster or epidemic preparedness, rapid reimbursement is a matter of readiness capacity. I think we can all agree that a lot is being asked from the public health infrastructure in our states. They're stepping up, they're coordinating, they're doing the right thing. On January 29, a flight carrying 195 Americans from Wuhan, China was diverted to March Air Reserve Base in Riverside County, the county that my district is in. Riverside County responded efficiently and was effective in monitoring and quarantining all of these passengers for 14 days. Over 40 county officials worked on this project. In addition, the county supplied food, transportation, quarantine supplies, screening, housing, a mobile health clinic, emergency management standby, and support services for ambulance. All told, these efforts are estimated a little over $1.3 million. And while that flight quarantine is over, the broader response continues in Riverside and in communities across the country. So receiving rapid reimbursement is critical to capacity readiness in the future. If you drain resources without replenishing them, you won't have necessary resources to fight this public health crisis, such as bedside diagnostics, personnel, and masks, just to name a few, and also having the resources to create preparedness plans, quarantine plans, et cetera, in the case of rapid transmission of this virus in the future. So I want to ask a question. Dr. Redfield, what are the funds that are available to reimburse state and local officials for their efforts responding to coronavirus?
I'll defer some of this to the Secretary, but I think he said in the supplemental a substantial portion.
Okay, so you're telling me the last time we spoke, you identified somebody in your staff mentioned a few. Now you're saying those funds don't exist. We need to pass the supplemental to reimburse counties. Is that what I'm hearing from you?
So we have the FEP, which funds California at $41 million a year, but the supplemental has requested $757 million
so
for
which
CDC,
funds,
which would have in that the state and local funding.
Okay, are there funds right now that counties can apply for?
No, there are not.
There are no funds.
No additional to the emergency funds that they get each year for these activities.
All right.
That's what the SUP is for.
Well, we're definitely
We agree.
going to work on that, and that's an issue, right? Because we were under the impression that there were, and rapid reimbursement is a matter of readiness capacity. If we don't rapidly reimburse, our local agencies will not be ready to deal with a potential rapid spread of the virus. Dr. Cadillac, Dr. Redfield, yes or no, can we get a commitment from you both here today that you will reimburse these expenses by local municipalities for the costs associated with containing the spread of the coronavirus?
Well, we're clearly going to work to see how to get that done.
Okay, so that's not a commitment. Cadillac?
I think the thing is we're committed to basically work with you to do that.
Okay, well, we need to reimburse because especially in rural areas where they don't have the resources, they don't have the hospitals, the quarantine spaces, the ability to get the supplies over to those areas, you're putting them in vulnerable situations if you don't respond. Dr. Redfield, since 2008, local and state health departments have lost nearly a quarter of their workforce. Does this affect our nation's ability to mount and sustain a response?
I think it's one of the key core capabilities that we need to continue to improve for our public health ability. That is the data and data modernization, which you all have helped with last year. The laboratory capacity to build it and keep it fluid, as you see with the current diagnostic test. And the third most important one is the workforce.
Work within a team, be consistent, no discrepancy. Discrepancy breeds anxiety, that brings panic. Okay? All right.
Expired. I wanted to get a commitment so that these agencies don't lose the money that they're losing. You're asking them to promise you even beyond where the cuts are. So I'd be happy if that could happen, but we've got, the Congress has a job to do to restore the money in these agencies. These cuts are really shameful. They really are. And when we have such premier agencies, people at the top that know what they're doing, and they're being cut. And the secretary is telling us, well, we did $1.5 billion, everything is going to be fine. I don't think so. Dr. Bouchon from Indiana.
Yeah, thanks for the 5 minutes. I appreciate it. No, 4 minutes. I'm just kidding.
Minutes.
I mean, in reference to the funding, I just want to, I mean, the Congress provides funding for the agencies, and a budget proposal is a budget proposal, no matter which president it comes from. So I'm not too worried that this Congress won't provide the appropriate level of funding, and I understand also that additional funding, if we could quickly bring up the supplemental and pass that, that clearly, in my opinion, would help Secretary Azar and all the people at this table do their job and get money to everybody. The other thing is, I just want to comment briefly on the criticism of the president and what he has said. If the president of the United States comes out and incites a panic in the United States, it incites a worldwide panic. And I see the role of the president as different than mine or Secretary Azar's or others. And even though, the president says what he says, I do think having a calming effect in a situation like this is appropriate, and allow the professionals behind the scenes to do their jobs. I just wanted to say that. And
if I could, I agree entirely. I think the president's role has been actually critical in keeping the country calm in this situation. He's expressed the levels of doubt and uncertainty with his words that we have, but also tried to be reassuring to the American public as we also try to be transparent about what the risks are coming forward. We all have different roles to play here, as you said, and the president's is a very important one, guiding towards balance, maturity, and calm in addressing a public health emergency.
I would agree. I mean, if the president came out and incited a panic, he'd be criticized for that. I guess, we had this unprecedented containment strategy when things were in China. Now that we know we've had problems with person-to-person transmission in Italy and South Korea, and maybe other places, does that change our current containment strategy? And Dr. Redfield, maybe you can address that, or...
Yeah, I would say first that we are maintaining aggressive containment. I want to say that of all the strategies we've used in this multi-layer strategy, the most important one that we have is an astute medical and public health community in the United States. Of those 14 cases originally that were diagnosed, all but one, only one was picked up by the screening. So we're now moving, obviously, to educate the American medical and public health community, and it's not just China we have to worry about now. We have to worry about certain places of Italy and Iran and whether it's Republic of Korea. So we're continuing with that, and we're continuing to look at our travel alerts. We've put travel alert to level 3 now for Korea and level 2 now for Italy, Iran, and Japan. So trying to let the American public know this may not be the time to go to those areas.
Okay, great. And again, for you, Secretary Azar, you have anything to add to that? Okay. Again, Dr. Redfield, as far as the testing goes, the CDC, 12 other public health laboratories have the testing, but I guess they had some difficulty with the third reagent in the test. And can you further explain the problems with the test, and have those problems been resolved?
So first, the test really measured three different, let's just say three different nucleic acid pieces. And one of them had a control, the third one had a control, and in that control there was low-level contamination. There was never any question about whether the test could tell positive or negative. It just had a group of individuals that we had to say we didn't know.
Okay.
And those samples, again, were at CDC. CDC's continued. We've doubled. I found out we're 350 to 500 samples a day when the question was asked earlier that we're running right now.
So the problem's been resolved, basically.
The problem's being resolved. We work with the FDA, and we have a fix that's supposed to be operationalized this week.
One other quick thing. Have you guys conducted disease modeling for a potential COVID-19 outbreak in the U.S.?
We do have modeling groups. It's a global modeling group that's looking at a variety of different models, and that's in process. As Tony said earlier, there's still a number of things we don't quite know about this virus to make those models available for prime time, but we are working at
working on it. Okay, thank you very much. I yield back.
The gentleman yields back. I think that concludes the questions that we have for you today. Thank you to each one of you. Mr. Secretary, you've been here for many hours, and throw a punch, take a punch, right? But we're all here for our fellow Americans, and I think if there's anything that's come out of this today, we want facts. We want to bring the temperature down. We want to bring the fear factor down, and anything and everything that you can do in order to achieve that as we move on with Dr. Fauci's work, with larger distribution of the diagnostics through the CDC in partnership with what we have across our country is going to go a long way. So thank you to each one of you. I'm not going to adjourn. You can get up and leave while I read a very long record of items that need to be placed into
Thank you, Chairwoman.
Into the record. Thank you. God bless you and your work on behalf of the American people. Thank you. All right, I'm going to request, I have a unanimous consent request to enter the following documents into the record. A June 28th letter from 4 House committees to HHS and CMS regarding the case Texas versus the United States. A December 2018 letter from 4 House committees to HHS and CMS regarding the case Texas versus the United States. An April 2019 letter from 5 House committees to HHS and CMS regarding the case Texas versus the United States. A February 2020 letter from HHS in response to the April 2019 joint letter from 5 House committees regarding the case Texas versus the United States. If the committee actually is still in order. I wanted the witnesses to be able to leave, but if anyone wants to gab, take it into the side room so that I can read these into the record, please. February 2020 letter from HHS in response to the April 2019 joint letter from 5 House committees regarding the case Texas versus the United States. An October 2019 Washington Post article entitled "Trump Campaign Urges White House to Soften Proposed Flavored Vape Ban," unquote. An October 2019 bicameral letter to HHS from 2 congressional committees regarding the increased number of uninsured children in the United States. A June 2019 letter from the Energy and Commerce Committee examining HHS's administration of the Medicaid program. A statement from Johnson & Johnson regarding the company's response to the coronavirus outbreak. A statement from the American Society for Microbiology regarding the coronavirus outbreak. A February 2020 article from BioCentury entitled, quote, "Biopharma Industry Academics Push Back Against Demands for Price Controls on COVID-19 Countermeasures," unquote. A January 2020 Wall Street Journal opinion piece entitled, quote, "Pharma to the Rescue," unquote. Are there any objections? Without objection, so ordered, and the subcommittee will now adjourn. Thank you, everyone.